STEMI. STEMI. Probably one of the more important things that we do with EKGs. You know, EMS is set up to do kind of three things, or we build the system to do a lot of stuff, but there's really kind of three things that I think of now that are the priorities for EMS systems, and that we build EMS systems around, not just stuff we do, but like what do we actually put people in places and make processes for. Largely, it's cardiac arrest, it's STEMI, and it's stroke. And stroke is coming in a little bit more there, but that's where you actually build your systems around. So it's pretty important, and we'll talk about it here. Sick hearts from are bad because you need that to go on. Now we can, get other hearts, but they're very difficult to come by, and so we want to preserve whatever myocardial tissue is out there, because while you can get a transplant, it's not like it's just sitting around the corner. So we kind of need to preserve as much of this as possible. And one of the big things that causes that to not work is ischemic heart disease, or STEMIs, or excuse me. Well, let's call it ischemic heart disease. The interesting thing about STEMIs is we think of them, we got to move really fast. This guy, good chance this guy's going to die. The mortality from a STEMI is not actually that high. When you look at it from back in like the 40s and 50s and stuff like that, the mortality rate's only about 40% in the first month. That's not too awful bad. The majority of people are going to live, 60% of them anyway. And you may be like, wow, I hope he's not being serious, because 40% is a really high mortality. Even if it's not that high, if it's a 10% mortality for this, that's still really high. And so we got to do a lot of stuff. We build a lot of stuff around keeping that from happening and opening these arteries back up. What happens when you lose blood flow to your heart? The muscle starts to die. So over time, as you build up little plaques in your arteries, it's sort of like a balloon. They get, oh God, it popped. And when they pop, blood cells will stick to the stuff on the inside of it, because they're trying to clot, because it's a disruption in your endothelium. And then when you make that blood clot, it stops blood from going through the coronary artery. And the arteries are not very big. They're not like your aorta. They're this little tiny thing that doesn't have a lot of space if you develop a clot in it. So the muscle starts to die. What part of the muscle starts to die? Well, when you occlude a certain vessel, all the muscle that gets blood flow from it starts to go after that. So if you occlude your right coronary artery about where that little cat is there, then all the tissue beyond it gets ischemic, and you infarct the lower area of your heart. And what happens when you put an EKG on somebody that is having that? You start with a normal looking EKG, you occlude it, and then you get that ST elevation and eventually develop a Q wave, kind of like we talked about last time. Now, why does the ST elevation actually happen? Magic. It has something to do with the way the muscle kind of doesn't depolarize quite right afterwards. And I'm sure there's potassium and there's some sodium in there, and there's stuff in channels. It doesn't matter. The point is, it does it. And you get ST elevation when you actually have heart cells dying, rather than ST depression when you have heart cells that are getting just low on fuel, are not getting adequate blood flow. We already talked a bit about the progression through STEMI, but it starts off normally, and then you get big ST elevation, then you develop a Q wave, and eventually everything irons back out over the course of days to weeks. But for the most part, what we're going to be seeing and what we're going to be looking for are these guys kind of through here, and then little tricks to kind of figure out the transition from here to here, as well as what we'll talk about. And if you've ever wondered what a heart attack heart looks like, this is what happens if you get a coronary occlusion that doesn't get treated. You develop a scar. This is the right side, left side. You develop a scar along that area of tissue, just like if you had, if you infarcted an area of muscle in your arm, that muscle area would scar down afterwards. Same thing happens on the heart. Scarred tissue doesn't really conduct electricity very well. It doesn't contract very well. And eventually it can actually balloon out, and you can get a ventricular aneurysm and actually rupture. We don't see that too much anymore, because I think most of these get treated relatively soon. And when we try to do good stuff with it, but that can happen. It's unfortunate if you do. Here's what it looks like if you cross-section a heart that has, in this case, an LAD occlusion. This is the left ventricle here, right ventricle, and you're kind of looking down on top of it as it's sectioned out. So you see the territory supplied by the left anterior descending the septum here, and the anterior wall you can see how that doesn't look good, and how that looks bad. You got to talk real quick about the territories that are involved. We did stuff about the axis already, but do remember that if you take the heart and you put those axes on there, they are looking at the electricity that's traveling in that area. So there we go here. If you infarct this area of the heart, where you're going to see the changes are in the leads that are pointing through that area, which is like lead 2, lead AVF, and to some extent 3, because it's looking at you can see them all kind of, let's see, there's 2, there's AVF, and 3 all kind of down this direction. They look at the at the right ventricle. So it's right coronary territory. It affects that area. You can see where it's scarred there. Wait, there we go. Similarly, if you blocked off flow to the upper part of the left ventricle, you might see ST elevation happening in the leads that go through that. So what is that? That's like, AVL. It's like lead 1. AVR is actually, it goes in the opposite direction, so don't worry about that. But those are ones where you normally see it. There we go. Okay. And then if you put out your precordial leads, as we sort of mentioned before, and we're now looking top down in a three-dimensional pattern with it, whatever leads go through the infarcting area, just like that, are the ones where you're going to get the ST elevation. So in this case, lead V1 gets the ST elevation, which you don't see all that much because it just goes through a little bit of it. But how about V2? Yeah, a lot of ST elevation there. V3, it looks right here, and you can see it's still going through that territory. So it's going to get a lot of ST elevation. And of course, I'm going through this kind of quickly and making a lot of assumptions, but it works out. V4, in this case, has some elevation, but not quite as much. It's just hitting the edge of the territory. But then V5 and V6 look pretty normal. And that animation didn't work out quite right. All right, well, that's cool. So we're trying to avoid this. We are trying to avoid dead heart tissue because dead heart tissue doesn't work very well. And you develop aneurysms, you get CHF, you can get papillary muscle rupture, and then your valves stop working, and then you can't pump blood effectively. All kinds of bad stuff happens in the first month to even 6 months afterwards. So we want to keep that tissue from dying. We want to get as much of it back as humanly possible. And so it's important to identify STEMIs to start off with. Now, the most probably important thing about this concept that I like to bring up is that you have to identify this early on, and as early in the patient's course as possible. Most people are going to take a little bit of time to call us to start off with, so we got to kind of get this all moving. What's the key to it? Early diagnosis, early recognition, early activation of the cath lab, early stuff, which, to stand on a soapbox for just a second, means that you got to take the monitor in the house. You got to take your bag of stuff in the house. You got to get this EKG in the house. It can't wait to get out to the ambulance. Some of these people will arrest. They may be perfectly fine looking and then go into cardiac arrest before you can even obtain your 12 lead if you're waiting to get out of the ambulance. So your stuff, we don't put things that you need right away. We don't put that all in the cabinets in the ambulance. It's in a bag with a handle, and there's a handle on the monitor, so that you can take that inside the house. You got to take the stuff into the house, into the Cracker Barrel, into wherever it is the patient is, because there's some stuff that just can't wait for you to get back out to the truck. So get back off the soapbox a little bit here. Back up, take your stuff inside the house, set them back off again. Okay. EKGs that indicate STEMI. This one looks pretty clear. Yeah, look anteriorly. Nobody hopefully is going to miss that. Everybody can see that that doesn't look like any of the EKGs that we showed before. There's ST elevation right here, a little bit out there. This looks abnormal. That's that, if you just looked out here, is that ischemia? That's probably a reciprocal change. And you see some ST depression here, those reciprocal changes. This is a clear STEMI, no problem. How about this one? Maybe a little bit less pronounced, but if you look at it, it's still there. You may be swayed by like, oh, this makes like the smiley face instead of making the tombstone. Well, it actually is flat, and I would just call it regardless. It localizes to an area. It's in the inferior distribution in lead 2-3 AVF, like right coronary territory. It's got ST depression in the contralateral, in the opposing leads laterally. This is a STEMI. That's what an inferior one will look like. You may see stuff like this. Again, not quite as clear though. Is this a STEMI? There's some ST elevation, or so there's some ST depression in there. There's maybe a little ST elevation. What makes a true STEMI a STEMI? I mean, like AVR seems to be elevated. Was that count? What makes it a real STEMI? What gives it the difference between this classic appearance and that classic appearance? What do we need to say to call something a STEMI? Well, we should be pretty, from our end, we should be pretty liberal with our calling of it, generally speaking, and call more things than not. But if you want to know truly what makes a STEMI based on an EKG, the ACC stuff says it's new elevation at the J point in two contiguous leads of 0.1 millivolt, which is a little box, one small box, in all leads other than V2 and V3. In leads V2 and V3, the number is 0.2 in men greater than 40 years old, 0.25 in men under 40 years old, and 0.15 in women. Now, what that translates to me into is mostly, I can't remember the cutoffs, but two little boxes in V2 and V3 and one little box everywhere else. You can make a distinction for men and young men. Young men tend to have, big muscular hearts, and so you get bigger QRS, negative QRS complexes that drive your J point up a little bit. So 2.5 little boxes in a young man in their precordial leads, like these guys right here sitting over top of the heart, that can be normal, normal-ish. Now, if there's any question, it's better to go ahead and act as if it was and let somebody else sort of figure it out. But that's why there's those things. Women tend to have less elevation. You see less of those changes, and so the criteria is a little bit different. We say 1.5. But things to kind of keep in mind. For the most part, keep in your mind about, it's hard to tell a difference of a half of a little box to start off with. So let's say two little boxes in V2 and V3, because I can't remember the specifics otherwise, and one little box everywhere else. If you have ST elevation in two contiguous leads that meet that stuff, that you should consider a STEMI. Here's the look of it again. We looked at some of these already. Not so much here. You don't really see the ST elevations, maybe a little bit of depression here, but inferiorly, you can see that there's just over a box, maybe a box and a half of ST elevation in lead 2 and in lead 3 and in lead AVF. So that's an inferior STEMI. And we won't talk about the stuff all that much, about the distribution all that much, except to say, what about this one? This guy is, ST elevation in 2, 3 in AVF. If you kind of look over as well, though, you might see that there's some elevation out in like V6 and some, maybe a little bit of depression there. V6 is usually a lateral. This is inferior. What does that mean? Sometimes, if you're trying to localize this stuff, they'll say, well, 2, 3 and AVF are like right coronary. V1, V2, V3 is kind of left anterior descending, and then V5, V6, and the 1 and AVL are circumflex. Your heart doesn't really know, it doesn't really follow, it doesn't set itself up to follow EKG distributions, and everybody's a little bit different. So in this case, it's actually the circumflex that feeds the back side of the heart and a lot of the right ventricle. I throw that out there. I'm talking too much about it. Ignore, forget it, don't worry about it. Again, with feeling, big ST elevations out here, most notably in the kind of lateral leads, and you got some ST depression here. But you'll notice that you do have that in 2 and AVL. So ST elevation greater than 1 millimeter in all the leads except for V2 and through V3. And let's just say 2 millimeters in V2 and V3. Same thing in here. Skip over that one because we're talking about these. There are some other stuff that falls in with it, like things like hyperacute T waves, which we'll talk about in a second. But there are things that should make you suspicious for STEMI, even if it doesn't meet the true STEMI criteria. Now, everybody throws in the left bundle branch block morphology as like, this is a STEMI is 2. The reason that everybody has always included a new left bundle branch block as equivalent to a STEMI is because it's been difficult to read STEMI out of left bundle branch block morphology because there's always ST elevation. That's the way it's supposed to be. We talked about that just a few minutes ago. You should have an ST segment that goes in the opposite direction of the QRS segment. So that's why there's always been the thing like we're going to call a new left bundle branch block as a STEMI. It's not necessarily that you might get a STEMI with left bundle branch block change. You could get a right bundle branch block from a STEMI. You could get a second degree AV block from a STEMI, or you could get no block from it. The left bundle itself is not really, pathognomonic or anything like that. And so we tend not to call it based on that anymore. The new left bundle branch block has kind of gone out of the way. Yes, it could be that they had a STEMI, or they could have developed the left bundle branch block 6 months ago, and we just don't have an old EKG to tell you that it's not new. So the new left bundle branch block stuff is sort of fallen out of favor a little bit, but you'll still see it in some protocols. All right, that's clear STEMI. Let's talk about some other stuff that's like a STEMI that it does not actually meet the like 1 millimeter of ST elevation or 2 millimeters of ST elevation, but you should still consider this to be probably a STEMI activation, if nothing else. One of the early things that we've seen, and folks are relatively familiar with this, one of the first things that you see, especially with like a left anterior descending, like an anterior STEMI, one of the first things that you'll see is maybe not elevation, but you'll see that the T wave gets really big. These are hyperacute T waves. And what makes it a hyperacute T wave versus another T wave? If you look at the typical T wave that looks something like that, it's kind of just a couple of millimeters. It's a lot smaller than the QRS complex. In this case, you look at that T wave, it's big, it's pointy, and it's in and of itself looks to be about double the height of the whole QRS. That's a really big T wave. Even the one in V3 is the size of the QRS complex itself. The T wave usually shouldn't be that big. Some people's are, depending on lead placement, depending on what you do. But a giant T wave like that, that's bigger than the entire QRS complex, in the setting of somebody that could be having a heart attack, you should really think hard, like, this is probably early changes. And if you get serial EKGs, you'll probably see that develop from just the large hyperacute T wave out to the actual STEMI stuff that we classically look at. This is kind of the same way. Now, this guy's got big QRS complexes, and so you can get big T waves with them. But again, the T wave is literally the size of the QRS complex. That should be, even out here, like as you're moving toward the lateral leads, that should be concerning for a STEMI. It is true, it is not a STEMI in and of itself. It doesn't meet that criteria quite, but it's awfully concerning for it. And you should probably be thinking about treating it almost exactly the same way and let somebody else tell you that it's not. And as a reminder to me the other day, this was a patient that I actually had. This was a person that had chest pain, nausea, vomiting, sweaty, looked like a guy that was having a heart attack, and got this EKG. Now, when you look at that, you're like, there's not quite, there's not really quite 2 millimeters out here. Certainly not 2.5. Maybe there's a little bit. It's not really out there. But again, when you look at that, you're like, oh man, that T wave, that QRS complex is really small, but that T wave is awfully big, which was the thought that literally went through my mind. I'm like, he looks like butt. His EKG has this big old T wave in there. I don't like this. I went ahead and activated the cath lab, and I talked to the cardiologist, and it was not thrilled about the idea, but we managed to come to the conclusion that, yeah, we should probably do something with this guy. He looks like he's having a heart attack. He's got an EKG that doesn't show he's not having a heart attack. So what do? They took him to the cath lab, and this, you can't really see that very well. You see that little spot in the middle of his left anterior descending there, that little pale spot, that's like a 99% stenosis of it. So he is getting just a tiny bit of blood flow through there, but ended up getting stented. And I would like to say we saved this guy's life. This is him in the after. Over here, you don't see that little spot anymore because there's a stent holding it open. Again, little tiny spot, and there it's gone because they've opened it back up. Hyperacute T waves. This guy could easily have just, sat in the corner of an emergency room if this wasn't recognized, and just continue to infarct his heart on and on and on until maybe he goes into VF, maybe he just gets terrible heart failure with it. This stuff happens though, so you got to watch out. And I'm not saying that I'm some sort of super EKG reader or super doctor. It's better to be lucky than smart. One other thing that can look like is not a STEMI but should be treated as if this is probably a STEMI is something that looks like this. And this is, again, just a morphology sort of picture. These are called De Winters T waves. So the T wave is, once again, big and concerning, but the part that makes it the De Winters pattern here is you see how the T wave actually starts like before the QRS finishes, before it comes back up to isoelectric, before it comes back up to zero, how it takes off. The T wave actually takes off at the bottom of the QRS complex below that line. That's a De Winters T wave pattern. This is like 2% of the MIs that are out there. That early takeoff of the ST segment, if the ST segment starts before the QRS comes back up to zero, to baseline, that's concerning. Does it again meet the STEMI criteria? No, it doesn't. Will somebody be mad at you if you don't activate the cath lab based on this alone? No, probably not, because a lot of people wouldn't recognize that either. But if you do see it, it's pretty specific. Like, I can't remember the numbers, like 85% specific for an LAD occlusion. It happens in the mostly LAD territory. So if you see something that looks like this, I don't think you would be wrong to call ahead and say we're bringing a STEMI alert in. So we've talked about the STEMIs. We've talked about the stuff that is not a STEMI but is concerning, like doesn't look like a STEMI, but you should be concerned about. Let's talk about the stuff real briefly that looks like a STEMI but is actually not, as I'm running out of time here. So here's one of them. Let's look at this morphology here. We see big Q waves in the anterior leads. We see a big R wave in lead 1. And you notice that there is ST elevation, and we see that there. But this is not a STEMI. This is, as we just talked about, a left bundle branch block. Big Q waves, the big R wave in lead 1. And you should see movement of the ST segment in the opposite direction of the QRS segment. So if the QRS is mostly negative, the ST segment is probably going to go a little bit positive. If the QRS is primarily positive, the ST segment is probably going to go a little bit negative. Not a STEMI, it's a left bundle branch block. Now, again, if there's question about it, if the QRS goes in the negative direction and the ST segment goes in the opposite direction, bad stuff. And that's potentially a STEMI, but this in and of itself is findings consistent with it. You see the same thing again, and this is another one that we just talked about, big negative QRS here, but you see these little blips, and there's no arrows to tell you 100% on this one, but the little blips are pacer spikes. So pacers will do kind of the same thing too. As we mentioned, whatever direction the QRS is going, the ST segment is probably, or it is allowed to go in the opposite direction. It may be flat. Talked about that enough already. Yeah, yep. Now, back to burn that in one more time here. What about this one? There is ST depression here. We don't see the big like left bundle branch block morphology. We don't see a right bundle branch block. It's a narrow complex QRS, but ST elevation here, it's significant. Here, a little bit here, a little bit here. What does that kind of tell you? Well, so every lead has ST elevation in it. Either this guy is infarcting his entire heart at one time, or he's got pericarditis, which is the big thing that you see with diffuse ST elevation. And in this case, it's pericarditis. So diffuse, if it doesn't localize to one vascular territory, good chance that it is pericarditis. This actually got put in the wrong spot, and I apologize. This is one of those ones that goes back to abnormal, should be probably has you concerned for a STEMI, even though it is not a STEMI itself. You look at this guy, and looking through his lateral leads, those look okay. That's maybe there's a Q wave there. You can kind of, you can get Q waves though in your inferior lead sometimes. I don't know if that's super significant or not. Well, maybe a little funky there, a little T wave inversion. Looking through here though, you notice again a big old T wave, but it's going in the opposite direction. And there's a little bit of ST depression with it compared to a relatively small QRS segment that persists all the way through here. This is another of those morphologies that you just kind of have to burn into your mind as this is concerning. Same thing here. That looks odd. Maybe we can't say exactly what it is, but it looks odd. It's a negative T wave, maybe a biphasic T wave. It's mostly in the precordial leads. That particular pattern is what's called a Wellens pattern. What this is classically in the LAD, you get an occlusion, right? And that starts to push the T wave up and it starts to push the ST segment up. But for some reason, that occlusion goes away. The clot kind of breaks down a little bit, or you take an aspirin and it goes away and they get a little bit better. And then the heart starts to reperfuse after that. And you start to get this pattern. So the guy could be pain-free when you get this EKG, but if you see that, you should be concerned. You should say to yourself, this guy has an occlusion in his left anterior descending artery because it's another one that's really specific for it. What you're basically seeing is that even if the clot kind of goes away, you get these persistent T wave changes. And you'll see that happen. You'll oftentimes see it kind of moving around, like they'll get more pain again, and that'll go back to like ST elevation or a hyperacute T wave. And then the pain will go away and it'll go back to looking like this. If you see this look, that like biphasic thing in V2 and V3, that's concerning for Wellens, and that means a critical LAD stenosis that still needs, maybe it doesn't quite meet STEMI criteria. It probably needs a cath because at any point it can reocclude an actual big STEMI dying kind of thing. This, by the way, from this person, here's the pre-hospital EKG 15 minutes before that, which does clearly meet ST elevation MI. If you had waited 15 minutes, like the time it may take to get the guy in the stair chair and get him out into the truck, you may just see this. But this is what his actual pre-hospital EKG looked like. Clear anterior STEMI. All right, what do I do with this stuff? I was going to say take a break here, but we're already running over, but we got started a little late. So I'm going to say, give me like 10 minutes. We'll finish it up here. What do I do with this information? I've identified a STEMI. Super cool. I have a tracing that looks like this on his monitor. He's alert, he's conscious. I got a 12 lead that looks something like this, and I noticed that there is ST elevation in the lateral leads. I'm thinking STEMI. What do I do with it at that point? What are the important things? What do you do with it? What do we all need to do with it? Surely there must be some reason that I'm asking that question. Well, what I was always taught in medical school anyway was based on 80s TV shows. And I was a child of the 80s. I was born in the early 80s. And so right as all the great stuff was happening through sitcoms was when I was coming up in the world. And everything I know about STEMI care for a while, I learned from Who's the Boss, based on one of the most beautiful women in the world, the most dynamic, the person that we all late at night thinking about. Of course, it was Mona, Catherine Hillman as Mona on Who's the Boss. What a fox. Being promised I'm not all that chauvinist, I'm putting on an act now. Classically beautiful, cute in a bathing suit, helps you save lives. Why? Because the mnemonic for what to do when you have a STEMI is based on Mona. Mona B. When you find somebody has a STEMI, you give them morphine, you give them oxygen, you give them nitroglycerin, you give them an aspirin, and you give them a beta blocker. And that's STEMI care. That's STEMI care 2000. God, when was that? Up till 2000, probably 10. That's all we were doing, all this stuff. This was my entire thing through medical school. And right as I became an actual doctor, all of a sudden, wait a minute, something happens. Mona dies. And so now what do we do? Mona itself, we hardly knew ye, but we have only the memory left. And for some of us, that memory is in our collective unconscious. If you're an older or longer practicing paramedic, you probably remember a lot of the Mona stuff because that's what we did. But what do we do now that we don't have Mona to go on anymore? We have to come up with a new mnemonic. Here's the stuff that's really important for pre-hospital STEMI care. I apologize for the really bad joke. I figured like it's a Pfeiffer type joke. Boy, a lot of setup for it. Anyway, here is what we need to do for STEMIs nowadays. We need to activate the cath lab. We need to give them aspirin. We need to put pads on them. We need to go to the cath lab or to whatever center. We should give them analgesics en route and nitro while en route. Okay, cool. How do we put that into a mnemonic? I'm going to make a few humble suggestions here. It could be something like this. That's not a great mnemonic. It's not really cool, but it actually covers everything in the order that you need to do it. Maybe we can come up with another one. How about if we change things around a little bit? And P. Yeah, no, it doesn't really. I don't like that one quite as much. It doesn't tell you the order that you need to do stuff in. So maybe we can come up with something else. How about this one? Ponda. Again, it's catchy and there's, easy to remember. I like that. No, you don't like that one. How about Panada? That's about my favorite there. I think I'm going to go with that one. Pads activate nitro, aspirin, drive analgesic. There's really no good mnemonic. I just can't make one. I literally probably spent an hour and a half trying to figure out a mnemonic for this one and make it like the Lubbers thing, and it's just not there. So fool's gold. Let's just talk about the stuff, huh? You're just going to have to remember it. Number one, STEMI, you got to activate the cath lab. Activate the cath lab from the house. Activate the cath lab from the Cracker Barrel, from the front of the target, wherever it is that you find that EKG. As soon as you realize this looks like a STEMI, you should call ahead to whatever cath lab you might be taking the patient to, assuming you're going to a place with a cath lab. But even if you're not, you should be calling the hospital and saying, I'm bringing in a STEMI because there's stuff that needs to happen. This is basically mortality from the time that you start occluding things to the time that you get the artery opened back up. So here we're at between 0 and 4 hours. There's a big fall off in that first 4 hours, and really in the first 2 hours, 2.5 hours, something like that, for how much good we do for folks. So we got to make all this stuff happen. And again, how long do people wait before calling the ambulance? Sometimes it's 10 minutes, sometimes it's 15 minutes, sometimes it's an hour and a half. We're sort of behind the 8 ball to start with, and we got to get this stuff rolling pretty quickly. There's still benefit to getting the treatments afterwards, but if you're really going to save heart tissue, you got to get it done in the first 2.5 hours, something like that. And that involves getting the person to the hospital, getting a stent or getting a wire put in through that artery, which you're seeing there, and then putting up a stent, which you'll see go up here in just a second, and restoring blood flow. So all that takes time. That takes probably 20, 30 minutes, something like that. And we've got to make all the other stuff happen in the meantime. In order for that to happen, you got to get the patient into the room. You got to get the cath lab open. You have to get a cardiologist into the cath lab, and you have to get the cardiologist's staff in there with them. And that can take time. Sometimes you really only have a couple of minutes, like half an hour to sort of make that happen before the point where there's really not a lot of benefit to hurrying anymore. And the pathway to the cath lab is fraught with dangers and perils and needs to change your direction, things that you have to do otherwise. So getting yourself as much time as possible is going to be super important. We'll just kind of skip over all this stuff. So whatever it is, if it's inside the house, if it's in the store, if it's in the back of the ambulance, as soon as you see the EKG, you need to pick up your phone or pick up your radio and call ahead and say, we want to do a pre-hospital activation if that's a thing, or we think we are bringing in a STEMI. We want to activate whatever the STEMI plan is so that all that can get rolling ahead of time. As soon as you recognize the STEMI, and probably before you recognize the STEMI, as soon as you heard heart or chest pain or shortness of breath or something like that, you should be thinking, we need to give an aspirin. This, aspirin, typical old Bayer aspirin, just fine. This is put up here as a class 1 level A recommendation, meaning basically based on the best evidence that we see, this is a good thing to do, and we should do it essentially all the time. 325 aspirin is just fine. And actually, in some of the earlier studies with this, basically they either gave people an aspirin or they gave them streptokinase, the clot busting drug, basically the only treatment that we had kind of like up till they started doing PCI more. Aspirin had as much mortality benefit as the clot busting drugs did. Regular old Bayer aspirin, it was like 162 milligrams or something like that. Not even the big one, but had just as good a survival benefit as all the other drugs did. That's pretty impressive. Now, not as good as a PCI. It's not great in of itself, but it has a lot of benefit to giving it. folks wonder sometimes, well, what if we could what if this to death? What if he took a baby aspirin this morning and then he took another one a little bit later on? Do I still give him a full strength one? What if he took one, but he's not sure exactly when he took it? It is better to get extra aspirin than not get one at all. So if the question is, if there's any question about it, remember, it's just an aspirin. Like a typical adult person can take 2 aspirin, no problem, at any point. My recommendation would be, did they take an aspirin after their pain started? If the answer is no, then go ahead and give one. And again, he got one this morning. Okay, he gets 2 aspirin in the day. He's going to survive this, almost certainly. And if the answer is yes, he took an aspirin after his chest pain started, then you probably don't need to give one unless it's been, 12 hours, something like that. In which case, again, if he takes another one, it's a second aspirin. People take 2 aspirin and call me in the morning. That's what we're really talking about. So better to get a little bit too much than not one at all. All right, we got to wrap it up here, lovers. Put pads on these folks. When you see STEMI, it is worth it to stick a set of pads on them. I'm not ragging on these guys, but this gentleman has a STEMI. This is real. They actually happen to have a crew at this air base. You'll see he's having a STEMI. He is conscious right now, and he's going to go into VF here in just a second. Well, I don't have time to show you the whole thing, but basically from the time that these guys, and again, these guys they're no slouch there. He's going unconscious right now. To the time they actually are able to get pads on this person sitting in a chair, it's like 2 minutes or something like that. It's this incredible length of time that you wouldn't think about. And these guys know what they're doing, and they kind of were prepared for this. If you can get the pads on the patient before he goes into cardiac arrest, before he goes into VF, totally worth it. And the incidence of VF after STEMI is something like 10%, which is really high. The $40-50 that it's going to cost you in a set of pads is 100% worth it for these guys that are actual STEMIs, because there's a high incidence, unbelievably high incidence that these guys will go into VF with absolutely no warning. So put the pads on them early. Then you got to get them to a place with a cath lab. What have we done so far? We've activated the cath lab. We've called ahead. We've done something. We have said this is a STEMI. We're going to treat him as a STEMI. We've given him an aspirin. We put the pads on the patient. Now we need to go to a cath lab or to a place with a cath lab if we at all can, because that's the best treatment for him. Now, and again, it's the best management for it would be to get percutaneous coronary intervention, or a stent, essentially, to get a wire in there, get that thing opened up. The typical goal is first medical contact to device, meaning the stent goes out, the coronary artery gets opened back up within 90 minutes. So 90 minutes from the time that you see the patient, they need to have a balloon up in their artery, opening it back up, if at all possible. You may say, if you live in a rural place, well, I don't live we're not anywhere near a cath lab. What it would require is driving, an hour and a half down the road to get to a cath lab in order to get this guy there primarily. And so our protocol says, well, let's stop off at another hospital. And you can do that. But here's the thing. There is a continuum for how much it actually benefits the patient. Like, the idea is, do we take him straight to a PCI center? We're going to just eat that time until he gets his artery completely opened back up. Do we wait that amount of time? Or do we try to take him to a smaller hospital, let him get fibrinolytics to try to start opening up the artery, and then transfer him on there? Which is better? It is all usually based on time, and that number is not definitive, and it kind of lies along a continuum. In the interest of speed, I'm going to skip to this part here. Basically, if you're under 45 minutes travel time, it is probably a better idea to go to someplace with a cath lab, even if it means driving past 3 other hospitals. If you can manage the patient, okay, manage their airway, manage the blood pressure, all that kind of stuff, it is probably more beneficial to the patient to go to a cath lab and bypass everything else. That may mean flying a patient. Now it's going to be really tough in that point, because you got to spin the helicopter up and that kind of stuff. But if you can get it done, it's within about 45 minutes. It's almost certainly better to get them to a cath lab. More than 45 minutes, you might consider about stopping at another hospital, getting the patient fibrinolytics, and then transferring them on to a cath lab. That's going to add in a step. That's going to take up some time. but it still may be worth it, especially if we get out to, like, if it's going to be an hour and a half till we can get someplace that's got a PCI center, then it is probably better to stop and try to get the artery opened at least a little bit and then transfer them on. What we don't know is 100% in this gray area where these two overlap. So for instance, in one of my services, we are 45 minutes from the cath lab itself, if you're in the center of the county. So half of the county theoretically should go on to Lexington, and half of the county should stop at one of the other hospitals and then get transferred on, at least based on the way the protocol works. However, as we've kind of talked about with the cardiologist, there is some leeway in there. That arrow can move a little bit. So if here we are, there's 45 minutes and we're right on the edge of that. If we expand that out to an hour, then we can basically get everybody in the county to a cath lab within that time period. Is that 45 minutes a hard set number? No, but that's something that you have to work out for your system. We think it's better to go ahead and give them the benefit. We're going to eat up that 15-minute extra drive in order to get them definitive care instead of delaying for another half an hour at the at another facility. If we see a STEMI, our crew's instructions are to move on, bypass the facility, and go straight to a PCI center. Each group is going to have to be a little bit different. Again, if you're under 45 minutes, easy no-brainer answer, bypass other hospitals. If you're above probably an hour and 15 minutes, easy no-brainer answer, stop at another hospital. In that interim, we're not entirely sure. So you're going to have to figure that out, but figure it out ahead of time. Just about done here. All right. When we're dealing with a STEMI, priorities. Number one, person has chest pain, they should get an aspirin in the house. They should get an EKG in the house. We call the cath lab from the house. You put pads on in the house. This is all stuff that you should do as soon as you recognize this. And then we should be moving the patient based on what we find in the house expeditiously, but safely, toward someplace that can do an intervention on them. So notice all this stuff. It all happens in the house. What you haven't seen is start an IV in the house. I would normally say do most of the care, do all that stuff where you find the patient. Except in this case, because in this case, the IV is not really one of those life-saving things. There's no benefit to it. We should be moving, and we can do the IV in the ambulance. And don't sit in the driveway and start an IV either. Once you get to the ambulance, all right, driver to the front and let's boogie. We can start an IV on the way there if we need to give something that way. You also don't see giving oxygen in the house because these folks don't need oxygen. If their SAT is above 93, STEMI patients don't need oxygen. We see people do that all the time, and it drives me nuts. These guys don't need it. And in fact, their infarct size may get a bit bigger if you hyperoxygenate them. So if they do not need the oxygen, if there's not an indication for it based on their SpO2, don't put oxygen on them. You don't need it. Ever. Not in the house, not in the ambulance. If their SAT is above 93, don't put oxygen on them in this case. Unless they're pregnant, in which case it's a different story. What about analgesics? We can do that. We should make these people try to feel better. Morphine is probably a fine thing to give, but most services are probably looking at fentanyl a little bit more. Fentanyl is a good choice as well. What about giving nitroglycerin? Sure. In true STEMI, it is downplayed a little bit less than just like regular old chest pain. And most of the recommendations say, well, maybe just consider giving fentanyl or morphine first. But nitroglycerin may help with symptoms, especially if they are markedly hypertensive, may bring their blood pressure down. Sublingual nitro will do it. One last thing. There was talk for a while about, well, should we give these guys beta blockers? Probably not. There is a survival benefit for STEMI patients that get beta blockers, but it's if they get a beta blocker in like that first day, and if they go home on a beta blocker from the hospital. Us giving beta blockers like metoprolol, which you'll see folks still kind of reaching and give for whatever reason, giving metoprolol or giving a beta blocker in the acute phase of the STEMI, the pre-hospital phase, actually increases the chance they go into cardiogenic shock. So we probably shouldn't do that. The idea makes sense, but it doesn't practically weigh out. Our bodies just are not tolerating it real well. So they don't need a beta blocker from us. If you want to get their blood pressure down, give them some nitroglycerin, which makes more sense for it. All right, time to get out of here, huh? STEMIs are 2 millimeters of elevation in V2 and V3 and a millimeter in all the other leads, and it should occur in 2 contiguous leads. Don't forget all the other stuff, the hyperacute T waves, the De Winters pattern. Look at it, learn it, because there's no good way other than just remembering that pattern to remember this stuff. If you see it, and as soon as you see the STEMI, call it in. This is a STEMI. It doesn't matter if it's 45 minutes away. Give them time to round up their folks, to get their plan in place, to get the other guy that may be on the table off the table, so that as soon as you get there, you can breeze through the EKG, or sorry, breeze through the ED and get this guy cathed in just a couple of minutes. Aspirin is good. It's everybody's friend. Yeah, if they're not having a STEMI then or chest pain, then you shouldn't give absolutely everybody an aspirin. But in the end, it's just an aspirin, and it's probably going to be fine unless they have some sort of terrible GI bleed they're dying from. It's just an aspirin. If they get 2 aspirin in the course of a day, all right, cool, better than none. And then make your plan, make your STEMI plan ahead of time. Figure out what it is that you're going to drive past. Hopefully everybody from me knows I want you to go to a PCI center generally, even if it's a little more than this state recommendation, which was 45 minutes. Why? Because it's not that much more for it. And I think there's a survival benefit. And I think the cardiologist generally would agree with me on that. So that's STEMIs. That's EMS Grand Rounds for February 2021. I appreciate your time and attention.